Well, hello everyone, and welcome back to another edition of the John Doe podcast. And joining me again for this episode is based Becky in her second appearance. So, Becky, welcome back to the podcast.
Thank you. Thanks for having me again. It's good to be back.
And yes, how are you doing today?
Yeah, I'm good. Yeah, I'm excited to have a conversation.
Good. We got some really good feedback on the last one. I think people found the conversation interesting, and there were some pieces of information there that I think a lot of people would have been quite surprised by. And I think it's really good to have these conversations with people who are, able to share things that perhaps the media isn't going to give you the full picture on. Now, for anyone who is watching this and hasn't listened to the first episode, obviously please do. I think it's a really good one. But just a bit of intro again for Becky. So Becky works in the NHS in pharmacy, and she's been with the NHS for 11 years. She initially did some training to become a nurse, but then decided not to go down that path. And actually in the last episode, Becky was telling us about how that was a good decision because the job of being a nurse, at least these days, has become incredibly difficult. And really one of the sad notes from that was the fact that, Becky was saying that she no longer feels as proud to work for the NHS, much as she's still very proud to work with her colleagues. And we were hearing about the commendable work they've been doing. The NHS overall is perhaps not what it once was. And one of the things Becky was telling us about in that episode was how over the winter patient care was really substandard, and this is largely due to under-resourcing of our hospitals. And I was quite concerned, actually, because we recorded that episode just going into winter. And so I think I wanted to start off, Becky, by asking, how was the winter that we're just coming out of now? Was this worse or was this better in some way? What was your perspective on the front lines?
I think it was slightly better, but that's not saying that it was good by any means. It was a little bit better. Waiting times in A&E were still horrendous. The trust try and do stuff to fix the problem of the bottleneck in A&E, but so this year they decided that to try and free up beds in A&E, they were going to create, in quotations, an extra bed in each bay up on the ward. But this bed space was literally just in the middle of the bay. So there was no curtain, there was no oxygen output, there was no emergency bell. It was just a bed in the middle of the bay with the patient. And they would wait there until someone else on the ward was discharged, and then they would just immediately go into that bed space. So it kind of took, normally on a ward there's about 6 bays. So it took an extra sort of 6 patients per ward out of A&E, but it was kind of robbing Peter to pay Paul, really, because, I don't know, patient dignity still wasn't really there because there's no privacy, there's no curtain around the patient. It's like if they arrested in the middle of the bay, if they had a cardiac arrest, like, they'd be just open for everybody to see, and there's no oxygen output, so I don't know. To me, it wasn't really like a great solution, but they're sure they had their reasons for doing it, but I don't think it was very good.
Well, it sounds like they're still very much underfunded and under-resourced as the reason for this. And I think we were talking before we started recording about the financial deficit. So can you tell us a bit about just the sort of financial situation some of these hospitals are in?
Yeah, so I'll talk about this in terms of like the patch that I work in, but I know that this extends to most trusts in the country. So, I mean, this has been going on for years and years. Like, it gets to the end of the financial year and we run out of money. So there's been times where I've been told we can't order any more paper because we literally have no more money. We can't order any more pens because we have no money. Name badges we can't order. Training courses now the funding has been ceased because they've decided that they can't fund additional training.
What sort of training?
So it's mainly for, like, again, I speak for my little area of the NHS in pharmacy. A newly qualified pharmacist will normally work for about 6 months, and then they'll have to do a postgraduate diploma. And they need to do that in order to progress and to continue learning, and then eventually move on to be a prescriber, which is one of the NHS incentive schemes for pharmacy. They want everyone to be a prescriber, which makes total sense. But now the trusts aren't going to fund this postgrad diploma because they don't have any money. So the students are now going to have to fund it. Bearing in mind these people have just done 5 years at university, they are going to have to come out and within 6 months fund 1,500 quid for a postgrad diploma. And our trust in particular, are now not even going to fund the study days for that postgrad diploma. So the pharmacists are going to have to take their annual leave in order to attend training courses. Like, it's pretty bad. There's just no money anymore.
That sounds crazy.
Yeah, it's awful.
So how much money and how much time are we talking that the cost in money and time that's now being placed back on the NHS staff rather than being funded to help upskill their staff?
Well, this particular postgrad diploma is about 1,500 quid, and depends what university you do it at, but on average there's about 8 face-to-face study days at the university, and then on top of that it will be additional time to complete assignments and essays and work for the postgrad diploma. So it normally goes on for about 12 months for the first year, and then the second year is when you do your independent prescribing. But if you're doing your independent prescribing, then NHS England will fund that, not the trust. So the second year is kind of taken care of, but the first year now they're going to be expected to pay for themselves and all their study days, and they'll probably have to take unpaid leave.
And what pay band and what sort of money are those people going to be on in the first place?
So for a pharmacist, when they finish university and they finish their foundation training year, which is the 5th year, so when they're completely qualified and registered, they'll come in as a band 6, which is about 35 grand a year, which is pretty good for a graduate, but bearing in mind again that they will be in tons of debt from university, most of them have moved out of home, and they're privately renting. And I know for sure when I was fresh out of uni and young and I was renting privately, I did not have 1,500 quid spare to pay for something, and I certainly couldn't have afforded to have unpaid leave to go for study days.
No, that's getting on for half your salary, perhaps.
Yeah.
40 something percent. And how much debt, now that, because we talked about this last time, how it used to be that if you wanted to become a nurse, you would get grants to help fund and support you in your training, and then all of that's been taken away. So how much debt is the average, pharmacy student in what we're talking about? How much debt are they likely to be in?
Well, pharmacy is not covered by the grant, and it actually never was, because I think the way pharmacy is kind of different to nursing is you can do your pharmacy degree and not work. A lot of people don't work for the NHS. The NHS has never funded it, but it's a 4-year degree, so we're talking 9 grand a year for that, plus all the maintenance loans that they need to get. I think they probably are coming out with about £90,000 worth of debt, these people.
And they're coming out starting with a gross salary of 36,000.
Yeah, roughly, yeah.
And then they're going to have to pay tax. And then they're expected to, presumably take out a loan again to fund another 15 grand's worth, plus that's coming out of their annual leave. And I'm just thinking, what's the return on investment for this anymore? How is this going to make sense for anyone who might have wanted to pursue that professionally? Looking at that just looks like you're digging yourself into such a financial hole. And if you factor in the cost of living and the increase in house prices and rental prices, I mean, how are they thinking this is going to be feasible for anyone to make that work?
Yeah, I don't know. I think in pharmacy we've been quite lucky that we have had this funded up until now, because I know that the doctors have historically always had to fund all of their extra courses, exams, and theirs racks up to tens of thousands over their career. The NHS has never really funded that for the doctors, so I guess we've been a bit lucky in pharmacy up until now. We're the next victim of the price cuts, but yeah, I feel sorry for these guys coming out of uni, because it's just going to be more money for them to have to pay out.
Yes, it seems as though we are lumbering the next generation of people going into the NHS, going into a profession where their whole purpose is to help the sick and the injured. These people, we're just lumbering them with debt and expecting them to pay to do their job, to the point where there's not really even the financial incentive for them to, I'm just trying to think, like, what is in this for people? What sort of life can you even expect to have on the money that the NHS is paying? And, that's going to be such a disincentive against people joining if we're already in a situation where they are struggling to recruit people. And I remember in the last episode you said that you left a position and a year later it still hadn't been filled. How are they expecting this to keep working? I mean, this looks like we're on track for the wheels to fall off, in the near future.
Yeah, and just going back to what you said, hilariously, when a post isn't filled, I think it's 18 months, if they haven't been able to recruit into that post, the department will lose funding for that post, because the trust will say, oh, we've managed 18 months now without this person, so we assume you don't need them, so we're just going to cut the funding for this.
That's a hell of an assumption.
Yeah, and it's stupid because it's not right, because it's like a death by 1,000 cuts, isn't it? It's like, oh, we've managed without this for this long, let's take that away. And then if you do that enough times, we're left with the state that things are in now, where there's no staff in A&E, there's patients waiting in there for 5 days to get a bed. Like, you can see at every point where things have gone wrong, and it is all sort of down to money and management.
Yeah, and it's crazy because we spend a huge amount of, all the money we spend in taxes and all the money that the government takes off us. We've got quite high taxes in this country, and we spend vast amounts of money on the NHS, unbelievable amounts of money. And yet our hospitals are underfunded, under-resourced and understaffed. I find it difficult to believe that we can be spending so much money and yet we can be in a situation where, the system isn't making ends meet. I mean, I don't know, like, where is the money going?
Yeah, I don't know. I also have that problem as well. I don't know whether I'm just completely ignorant, but I see the amount of money that gets pumped into the NHS, and I often question, where is that going? Because it's not going on recruitment of staff. Like, where is it going? I actually don't know. And I know we wanted to talk about deficits, financial deficits. So just to give some examples, where I work, like the area that I work in is made up of a couple of councils, so it's fairly large, but the deficit in that one area of the southeast of England is 33 million for
Wow.
1 year.
For 1 year?
Yeah.
And so that is one of how many? like districts or areas or
I call them patches. The
Patches.
official name is ICB, which is Integrated Care Board.
okay.
I mean, there's loads that around. So in southeast of England, you'll have, I think you might have several in London. Then you'll have Kent, you'll have Sussex, you'll have Surrey Heartlands, Hampshire. So it is kind of broken up into counties.
And are they all in a similar position of being in a financial deficit?
I don't know for certain, but I would imagine so. Yes, yeah.
Yeah.
For sure. Maybe London is a bit different. The London trusts tend to get quite a lot more funding, and a lot of them have got charities attached to them which raise a lot of money for the trust. Like, for example, Great Ormond Street, Guy's and St Thomas's Hospital, they I think they do pretty well out of their charities because they're fairly big names. So I don't know about them, but yeah, £33 million for just one integrated care board.
And what is the impact on patients? We discussed how there's, a lack of dignity given that patients are... I mean, last time I think there were literally patients being put in cupboards or storage rooms to die so that at least they weren't dying in front of a load of strangers. I mean, it's really horrific. Like, you've got to imagine if that's your mum or dad or your grandma or grandpa or someone you care about, and that's how they go because the NHS is just not being given the money and the resources it needs to provide anything approaching decent care to give your loved one dignity at that point. That's just one example. I mean, what are some of the other impacts that this lack of funding and lack of resources are having on patients?
I think it's just like bad patient care in general. So it could be anything from like what we were talking about in A&E to up on the wards where patients are not being cleaned in a timely manner because there just aren't enough nurses around or healthcare assistants. You'll have people in agonising pain waiting for pain medications either to be prescribed by a doctor or administered by a nurse because there just aren't enough people. I mean, quite often you'll have one nurse to 2 bays, so that's 12 patients, and then maybe 2 healthcare assistants. There just aren't enough staff to go around, and the staff do their best, and then that has a knock-on effect to the staff and their mental health and burnout, and you get a lot of sickness and long-term sickness. And we saw this a lot after COVID, actually. A lot of people went off with mental health issues, PTSD as well from COVID, and full-on burnout.
Yeah, that's. I'm glad you mentioned that because I was going to ask about the impact on, it's not just the patients, it's also the NHS staff themselves having an incredibly hard time and having to deal with the sorts of things that most of us wouldn't experience perhaps more than a few times in a lifetime. You guys are on the front line, and just people are in a terrible state. They're dying. They're very sick. They're suffering, and it must be so difficult not even to be able to give them the care that they need in that situation. And so I suppose I've got a few questions about where this money could be going. So we have a situation where, despite throwing vast amounts of money at the NHS, trusts are still so underfunded that they cannot hire and recruit and retain the staff they need, and they can't fund the resources they need to give adequate care. They don't even have the space for it. But there are some things that the NHS does seem to be finding money for, and I think a lot of people have kind of cottoned onto this, and there are questions around the priorities of those allocating the funding. So, for example, can you tell us a bit about the Green Initiative at the NHS?
Yes, so this initiative is an NHS England thing, so it's across the country, and they want to be carbon neutral by 2040. They want to be the first healthcare system in the world to be carbon neutral, which I think, in my opinion, there's just so many flaws to this thing. I don't even know how a healthcare system can be carbon neutral. I don't understand why that should be a priority for a healthcare system. And I don't understand why that should be a priority for the NHS when it's crumbling from everything else. And yet they can stand up at the end and be like, oh, but we're carbon neutral. It's like, oh, okay, great. So in our trust, and I had a little search as well, and there is recruitment going on in other trusts. I'm sure it's going to get bigger. We've just hired 2 people. One is the clinical lead for sustainability. I have no idea what those words even mean. And I think they must be on about 50 to 60 grand a year, maybe more. If they're a clinical lead, they could be on 60 to 70. And then another sustainability person who might be on about 30 to 40,000 a year. So both of those people, let's say that the trust is forking out 100 grand a year for these 2 people. And I don't know what they do. We kind of had a laugh about it at work. Like, are they just going to come around and tell us to recycle more? Like, I honestly, like, no offense to those people. Like, I'm sure they're really proud of their job, but like, if they gave a lecture about what they wanted me to do, I'd just be like, there's no way I can do that. Like, it's just not a priority in my head. I don't care.
Yeah. This is crazy. And how many? So this is going to be happening across the NHS and across the country.
Yeah.
So they must be throwing millions of pounds at this.
Yeah. And then there's like pharmacy now have got a KPI for NHS Green, which is to reduce the amount of metered dose inhalers because they emit too much CO2, and to change patients over to inhalers that don't emit so much CO2, which, okay, fine, but that's a massive piece of work. You think about the amount of people who are on inhalers. It's not just going to be something that you can do in an afternoon. Like, we're talking years of work, really, to review patients, speak to patients, get consent from patients, make sure they can actually use the new devices. Like, it will take years to do this.
How much CO2 do they think this is going to prevent from being put into the atmosphere?
I can't remember exactly, but I think one of the stats that they had was over a year of using a metered dose inhaler, which a metered dose inhaler is what you would think of immediately when you thought of an inhaler. Like, it has a little puffy thing at the top and you breathe in.
So is that like for like Ventolin?
Yeah, exactly. Yeah, Ventolin inhalers. I think they said over a year. It's like the equivalent of driving to Devon and back or something. It could be driving to Devon and back 10 times, or I don't know. But
with one car?
Yeah. I was just like, again, like, this isn't really a priority, and like the amount of work that it's going to take. And also, you have the devices they want to switch to are a little bit more fiddly. And for elderly patients, especially, they don't have very good dexterity in their hands. So quite often, if they get put onto these different inhalers, they can't use them. They don't understand how to use them, and you have to spend time counselling them how to use them. And like, elderly patients like what they know. They don't want change. They don't want to deviate from what they know. And children as well, like, having a simple puffer inhaler, like, is so much easier than something that you might have to fiddle about with a bit more. Some of them are breath accutated, which means that it relies on having a good lung function to be able to breathe in quite strongly, which we don't recommend for elderly patients because quite often they can't do that. I'm sure they won't be switched if it's not suitable, but then you kind of think, well, then the whole initiative's a waste of time then, because if we can't switch, let's say 60% of people, then it's just a waste of time. Like, why are we doing this? If the inhaler's working, it's working, and it's cost effective as well, because the the newer inhalers are more expensive. So they'll find the money for that because it's green. They won't find the money for 10 extra nurses in the trust or whatever.
I mean, this just strikes me as a level of incompetence that I can't even get my head around, to think that the ROI on something like that to save a few car journeys to Devon's worth of CO2, when you've got people literally dying in wards because there aren't enough nurses, but they're hiring these people for the Green Initiative. I mean, that I'm kind of gobsmacked by that. Okay, so this is one area that the money seems to be going to, and this is part of the reason, presumably, that we don't have more nurses, because that money could hire more nurses or fund more equipment. One of the other things that people have noticed, and I think there've been, there's been some stuff in the media about this, and people have raised questions about, is these new roles that have come in over the last 10 years, perhaps, of people with job titles like diversity lead or head of diversity and inclusion, or all of these kind of rather nebulous terms. Can you tell us, a bit about what that looks like in your NHS trust, what you know about them, not so much who these people are, but like, what is their role? What are they getting paid? And again, how much NHS money, which we've seen is so scarce, is being allocated to these people?
Yeah, so we have one person in our trust who's diversity lead. I think they're called EDI lead or whatever. I think they're a director, or like they're pretty high up, but they must be getting paid at least £80,000 a year to be this diversity lead. And again, no offense to these people, but I don't know what you do on a day-to-day basis. I'm sure they think what they're doing is very noble, but it's just not a priority, I don't think. I mean, I suppose their argument would be, oh, it's easy for me to say that because I'm white. But I mean, come on, like just in our hospital, we have so many different ethnicities, and people progress into senior positions no matter what their race is. It's irrelevant from what I can see. And all I can see these people doing is just like celebrating Black History Month in the trust. And I wanted to send you a picture. They had like this book display in the library of all like, these new books that come out, like Why I Don't Talk to White People About Race Anymore, and like all of these books. I really wanted to take a picture and send it to you, but I got scared that someone would want to come talk to me about it, and I just didn't want to have that conversation. So
I mean, with things like that, I think that's the book. Is that the book Why I'm No Longer Talking to White People About Race?
Yes.
And there's been a few books like this. There was another book by a lady in America, a Jewish American author, Robin DiAngelo, called White Fragility. And more recently, I saw one that was titled White Rural Rage. And this just sounds like a taunt.
yeah.
Do they think this is going to make people feel like, oh yes, we're all part of a nice, warm, fuzzy, tapestry of people? Or is this, because it seems more like it's designed to provoke and antagonize white people. But again, that aside, there are patients, even if you've got the diversity angle and you're saying, oh, well, you're white, blah, blah, blah. There are a lot of patients in the NHS who are not white, who are from, all other parts of the world, who have immigrated here in large numbers in recent years. They're going to be dying too if they're not getting the right care. They're going to be suffering too. So even if their argument is that diversity is important, if your priority is these kind of like ideological drives where you're trying to propagandize people to think the way that you think and to have the values that you think are right on and woke, and yes, this is if your priority is that, when patients of all colours, of all races, are dying from lack of care, then again, the allocation of funding to this, I don't know how they can justify it. This seems insane.
Yeah. Well, they justify it by, they have this thing called health inequalities. So, like, their argument is that BAME people have worse health outcomes than white people. So that's kind of their justification. I mean, I don't know it. I've never looked into this data. I have no idea whether it's true or not. I struggle to think why that would be true. But that's the kind of their justification in their head, is that they want to even out these health inequalities that they go on about. And that's now infiltrated into the training of our staff as well. So we're now having students, like, for example, my husband's a physio, and his students, his university students who come on placement, the criteria that they're getting marked against now is, are they aware of health inequalities? What are they doing to equalise health inequalities and all of this extra stuff? And so, yeah, it's becoming wider now. It's infiltrating the training.
And they have time for this when there are people who are screaming in agony because they haven't had their pain meds.
Yes, they must be audited on the health inequalities.
And this sounds like the sort of thing where I mean, one of the basic things when you look at any sort of statistical analysis is that correlation does not equal causation. So I can well imagine that you might be able to look at a demographic breakdown of people in the UK and observe that people from certain ethnic backgrounds might have worse health outcomes, but that doesn't actually tell you anything about the quality of care that they've received, because there are lots of other factors. So, for example, I believe people of African descent are more prone to sickle cell anemia, and I think this is something that evolved because of, I think it gives them better resistance to malaria, for example, but it also means that they're then more susceptible to this. And there are lots of other things, actually. It's quite interesting how, people are from different backgrounds. Actually, there are significant biological differences. There are also differences in lifestyle, and there are differences in socioeconomic status, which, regardless of how you may wish that they were different, the fact that those are causal factors that can lead to different health outcomes that have nothing to do with what they're probably implying is that they're inferring that, okay, there are different health outcomes. Now, we haven't specified what those are, but I imagine they're looking at that and making a very simple inference that this must imply that there is unequal care provided in the NHS. And so, therefore, we have to look at the NHS and we have to audit everything. And I can imagine them going on almost a witch hunt to try to say, okay, there must be some institutional bias here. When in actual fact, what I would say is more likely and certainly needs to be disproved first is that it's not actually caused by other factors outside of the control of the NHS and of people there, rather than just assuming that it's a failing of the NHS along those lines. And it seems especially bizarre given that we hear so much about the ethnic diversity of the NHS itself. There are so many people working in the NHS who are not of an indigenous white British background that you would think it's very strange to see these patterns of, to see bias in that way when, half the staff or whatever proportion of the staff, maybe 30 or 40%, are from non-white backgrounds, and everyone else is working in very close proximity with colleagues who are, even if they are white. So it seems like a bit of a stretch to assume that.
Yeah, definitely. Yeah. I mean, we know that genetics plays a huge factor in like what diseases that you're predisposed to. So there's definitely more beneath the surface than just looking at this data and saying, oh yeah, well, black people are more likely to die in childbirth or whatever. It's like, okay, but why? Like, you can't just take that piece of data and immediately assume that everybody's racist. Like, there are lots of different factors. You're right, socioeconomic factors, genetic factors. Like, it's never just one thing.
Can you tell me about any other examples of those sorts of differences, whether it's biological or cultural.
What, like with health outcomes or?
Yeah, so are there things that are sort of, either these biological differences, or perhaps even cultural differences that are sort of known within the NHS to cause differences in, the sort of diseases people might come in with, the sort of issues they might have, and the sort of care and treatment that they require?
Yeah, well, we know like people from South Asian countries are more likely to have type 2 diabetes. So kind of like when we're talking about people being overweight and getting type 2 diabetes, people from South Asia are way more likely to have type 2 diabetes. People with brown and black skin are more likely to have vitamin D deficiency, especially in our country where there's not enough sun. They're just not evolved to be able to get vitamin D from this low sun level, so a lot of them suffer with that. Socioeconomically, some of the poorest areas in this country are more likely to be addicted to prescription medications. Although, like, it doesn't matter whether you're rich or poor, if you're going to be addicted to opiates or prescription meds, it seems to be the pockets of society that are the poorest, like the Northeast and Glasgow, which are predominantly white areas as well, which is interesting. They're more likely to be addicted to prescription medications.
Okay. And then another thing that I wanted to ask about, because I think it's really interesting to look at the situation where the NHS is so seemingly underfunded when it comes to putting in place the nurses and the resources that are required, and we've got people who are suffering and dying due to lack of resources, and yet we seem to be spending such a vast amount of money on it. So another question I wanted to ask is about the quality of people that the NHS is able to recruit, and how difficult it might be to get rid of people who are less competent. And I don't want this to sound disrespectful, because I know that there are so many people who work in the NHS who are very competent and who deliver exceptional care and who work themselves into the ground for the sake of other people. And obviously a lot of them are not doing it to get rich, as we've seen. So I want to preface this by saying I have the utmost respect for those people who are on the front lines and really doing incredible service to the people of this country. But there's a couple of issues around not being able to hire people very well because they're not attracted based on the amount of money you can offer them, and then actually needing to recruit people more broadly. What I'm getting at is, it seems like you'd have a problem of not being able to hire the best people or the most competent people, because those people are probably going to want other jobs in other areas where they can make more money and have a better standard of living. And also, I've heard that there are huge bureaucratic barriers in the NHS around firing incompetent people. And I mean, anyone who works in a company where they have incompetent colleagues that everyone knows they are slowing things down, knows how difficult it can be. And I think when it comes to a profession where people's lives are literally depending on the quality of care, and perhaps that's also dependent on how well everything is managed and organised, I think that's a significant risk factor if you have people who don't have the level of competency that you really need for someone who has such an important role. So can you tell me a bit about your experience of, the sort of people who are hired and where you have issues around people whose competency is not where it needs to be?
Yeah, so you're totally right. It's basically impossible to be fired from the NHS. It's extremely difficult to get rid of anybody who is underperforming. If you do need to, often this process takes months, sometimes years. So the hiring and firing processes and systems in the NHS are very bureaucratic. So like I say, it's basically impossible to be fired unless you are struck off of your governing body. You're pretty much not getting fired. And the way the NHS pay bands work, so every year you have to have a PDR, which I'm sure most people have, like a personal development review or whatever, where you set goals for the year and everybody loves it. Not. And in order to get your pay progression, you have to meet your goals. Okay, fine. But what happens when you reach the top of your band? So now the pay bands have all been redone in the NHS. Most pay bands have only got 3 increments. So let's say you've been at a band 6 for 5 years and you're at the top of your band, and you still need to work a bit more to get a bit more experience before you can progress, or actually you're just comfortable and you really like your job and you don't want to go into management and that's where you want to stay. Cool. But then what's the point of setting goals? Because even if I meet them and I work myself to the bone to meet them, I'm not going to make any more money because I'm at the top of the band. So to me, that's a problem, because you could have somebody who is absolutely amazing at their job and they've been doing it for 20 years, but they are never going to get a pay rise, ever. They will never be rewarded for their hard work after 5 years or 6 years of working at that band. And you could say, oh, well, it will encourage people to progress. And it's like, yeah, but there are a lot of barriers to progressing. Like, for example, the interview process in the NHS, which is extremely frustrating because it's very bureaucratic. And I can't speak for other professions, but when I've had job interviews for my profession, 99% of the questions are just about bureaucratic processes. So you'll be scored from 1 to 3 of your answer, and like most of the questions will be like, what are the trust values? Give me an example of when you demonstrated this trust value, or give me an example of when you worked as a team. And it's like, okay, I could answer all of these questions really well, and there could actually be no clinical questions in the interview to actually judge how good I am at my job. And I will still get the job because I've been able to answer these other questions. So that happens quite a lot. So you could hire someone who's a really good team player because they answered the question right, but actually they are not very accurate and they don't have very good clinical knowledge. Well, they're not going to be a very good pharmacist. So the hiring and firing processes in the NHS are weird, and I really have a problem with them. I've been quite vocal about this at work because I have been stung a couple of times where I've gone for promotions and I haven't got them. And you could say that I'm bitter and sour about it, but like quite often the outcomes have been unfair. So I've been in this profession for 12 years and I went for a promotion, and somebody who had only been qualified for a year got the promotion because they answered these questions better. And okay, obviously I'm biased because I thought I was better suited to the job, but to me that seems ridiculous.
It seems ridiculous to me too. And I have to be honest, the first thing that comes to mind is was there a diversity element within this?
In that particular example?
Yeah.
I don't know.
I mean, was the person who got the job not of a white ethnic background?
No, he was white.
Okay.
He was a guy. He was white. I don't think it was to do with that. I think it's to do with like the scoring process. And the NHS will argue, oh, well, we need to make it fair. We need to make it fair for everyone and equal. And it's like, fair and equal for who? Because it wasn't fair and equal for me.
Yeah.
Because I've been slogging myself out for 12 years and I didn't get a promotion.
And it seems like they're more interested in your ability to assent to their sort of ideological values than they're interested in you being able to display competency from years of experience that demonstrates that you would actually be capable and effective in that role. And again, it just seems like the NHS priorities are completely back to front.
Yes, I would agree with that statement, definitely. Yeah, they're measuring you against. Yeah, I mean, being a team player is important, but is it more or less important than being able to do a complex calculation for a drug? Probably less.
Becky, can you tell us a bit about the guaranteed interview scheme at the NHS?
Yeah, so I'm not an expert on this, but I have been reading about it a little bit because I saw it on a job advert a few months ago for a first responder in the ambulance service, which is a voluntary position where you're the first person that goes out to a cardiac arrest and you administer CPR. And one of the things on the job application was this guaranteed interview scheme, and it was anybody who had a disability, and on this particular one it was anyone who was from a BAME background was guaranteed an interview. And I was a bit like, what? Is this a thing? So then I started looking a bit more into it, and it is actually a thing. Not every NHS trust and not every job role in the trusts will have this. I don't know how they allocate it to what job. But yeah, it's a thing, and trusts can sign up to it, and it can be if you have a disability or if you're BAME. I think it's mostly for disabilities, but like I say, I have seen it for the BAME backgrounds. Then you're guaranteed an interview, which seems a bit unfair considering that the NHS job application process, when you're shortlisting, you don't see the person's name, you don't see their if they have a disability, you don't see their ethnicity, you literally just see their job history and their personal statement. So I don't see how you could possibly discriminate anyway.
So they're already doing colourblind recruitment, as it's known.
Yeah.
And yet they've still got this. And that does seem bizarre, because surely you would be, when you're looking at people who might apply for a role, there are all sorts of factors by which you might just automatically screen some people out. And this could be, just the quality of their application is barely intelligible. Some pretty simple things where you can just rule people out. But are they saying, so they're saying that if you apply for this role and you are essentially non-white, which is what BAME, BAME is creates the silhouette around white people, because it means everyone who isn't.
Yeah.
They're saying you will get an interview. I mean, again, this sounds like what they're not taking into consideration is the time that's going to take to interview X number of people who any sensible person could probably have discriminated against, not on the colour of their skin, but on the fact that, as anyone of any race can be, they happen to be unsuitable for the job. And I mean, if you're saying that you want equality, there's got to be equal treatment on both sides. You can't just say that it means that you give one set of people opportunities without any criteria. You can't hire someone who is illiterate to run an NHS trust just because they're not a white person and you'd like a white person to do it. You actually have to have someone who can do the job regardless of the colour of their skin. So again, this just seems bizarre that they wouldn't factor in the cost that's going to have. And I wonder if this is what those heads or those diversity leads on their 80K are coming up with.
Yeah, it's probably something that they're championing. Yeah, you're right. It is a waste of time, because you could end up interviewing somebody who hasn't got the experience, or they're just not right for the role. And like I say, I just feel like it's irrelevant because when you're shortlisting in the NHS, you don't see those metrics anyway. So you couldn't possibly discriminate in the first place, even if that was an issue. You can't see that information. So it's just virtue signalling, isn't it, really?
Yes, it sounds like virtue signalling, and it sounds like these people with their cushy 80 grand jobs trying to justify their existence and say, oh no, I know you'd like to hire some more nurses so that, this person's grandma doesn't die in front of 12 people in a state of complete indignity. But look at this diversity drive where we're saying that everyone gets an interview. So give me the money. I mean, it's just, oh God, it's just beyond belief, really.
Yeah.
And then the other thing I wanted to ask about is, we discussed how the NHS struggles to recruit domestic staff. It struggles to recruit, particularly nursing, because no one, obviously, any sensible person is going to look at what the job actually is. You're paying for your training. You're not getting paid very much money at all. The hours are horrendous. And all these other factors now that make it a very undesirable job. But I suppose for people who want an opportunity to come to the UK, the overall package there is still making them actually want to go ahead and do it. And so they're recruiting people from other countries. But, I mean, the scale of... we're not in the 90s anymore. I don't think anyone can pretend not to have noticed the vast scale of mass immigration into the UK. But I'm interested in how this affects, really critically important things such as the quality of patient care, and that can include bedside manner. So what tensions and what issues, speaking candidly, and again, if there aren't any issues at all, that would be wonderful. But is it the case that there are issues created by having such a huge influx of people from different countries, with different backgrounds, with different cultures, with different values, who English isn't their first language. Again, for any sort of right on people, put the genetics, the race part aside. Just looking at culturally, and in terms of values and the kinds of people who are from a very different background, what sort of impact does this have on patient care?
Yeah, like I've definitely noticed speaking to patients that they'll have preferences to what nurses that they like looking after them, especially elderly patients. They'll often say that nurses perhaps from West African countries are quite harsh. They haven't got the same sort of sense of humour, and they kind of exhibit this sort of tough love, hard form of nursing, which quite a lot of older people don't particularly like, and they will say quite frequently, the night staff, I didn't like that nurse, she was not very nice, or she was rude, and that's definitely a cultural thing, which is fine if you can address it with the person, and you could say to that staff nurse, or like, could you try and be a little bit more empathetic, or less harsh in your practice, like this is how we would like you to go forward. But you just can't have those conversations because of the whole race thing and it being offensive or insensitive towards them. So people just wouldn't dare say anything, be too scared.
Really? So there's a problem with the bedside manner of these nurses from West African backgrounds in particular, and probably other backgrounds. This is widely known, and patients are complaining about it. NHS staff are aware, but they're too afraid to raise and address these issues because they're afraid that the assumption will be that it's not a concern for legitimate reports of substandard care and of bedside manner that, if it was a white person, they would probably be reported. It would be addressed, no doubt. The assumption would be that it's just this same old thing where there just seems to be the presumption that we're all secretly racist and prejudiced, and that that's how it would be framed, and that no one would be taken as acting in good faith. That no, these patients are complaining, this nurse's behaviour, it doesn't matter who they are, the behaviour is a problem and it has to be addressed. NHS staff are not able to do that because they're afraid, presumably. And I mean, have you seen people try to address this and get shut down, or are the people so afraid that they wouldn't even bring it up?
Yeah, people would just not bring it up at all. But this is a culture in the NHS that is quite prominent, because you'll have arseholes all over the shop. So, consultants can quite often have terrible bedside manner, and doctors, and they could be white, black, brown, whatever, and that will never be addressed either. Like, these patient care bedside manner problems are often never addressed, either because of a racial thing or a hierarchy thing. So people will just get away with it, or they just won't know because of the cultural differences. They would just never, they don't realise that they're being harsh because it's normal to them.
That's crazy. And I mean, I've experienced NHS consultants myself, and I know that some of them can be great, some of them there is no bedside manner. You just don't get that, and you're treated. You can be treated with what feels like contempt. But I think, that really is a very serious issue, and it's bizarre. This kind of theme that where people they're talking the talk of equality, and saying, oh, we should treat people the same regardless, but they're not treating people the same. They're treating people differently. They're treating people differently because of their race. And if you actually wanted to have a completely colourblind view, you wouldn't, that wouldn't be an issue. You would say, well, look, this is a behavioural problem, and we need to address the behavioural problem. In a world where it actually was based on racial equality, there would be no issue with going in and saying, look, your behaviour, what you are doing, your actions, is the problem. Dare I say, I've got that wrong. What was it? Not the colour of their skin, but something of their character. Is it the quality of their character?
I know what you're trying to think of. I can't remember either.
MLK. It's the yes, content of their character.
How funny! We both knew exactly what you meant, but we couldn't quite think of it.
Well, maybe we'll edit this out, or maybe it will be a funny little. What would you say?
It's content.
Comic relief. Yes. So what I was trying to say is that we are literally saying that we are judging them by the colour of their skin rather than the content of their character, as manifested in their behaviour, their bedside manner. Now, I think the thing is, if you were to really think about this, the reason why they wouldn't want you to address that is because then you might see a pattern that quite a lot of people from a particular background actually are exhibiting behaviour that is problematic. And I think their instinct would say, well, what conclusion might that lead to? Because it might be that if you were to address this from a colourblind perspective, you would then still end up with an outcome that is impacting the majority of the people, say, from West Africa, because it's that cultural problem, which happens also to correlate with their race, given that they're from Africa. And I suppose what they're afraid of is that people might look at this and the conclusion that might occur to them is that, look, maybe this is a big problem hiring lots of people from West Africa in the first place. But, they're not even giving anyone the opportunity to try to avoid that conclusion by addressing it with the nurses and saying, well, look, you've got to change your behaviour. We're not even giving them the chance. And it's kind of patronising in a way as well. It's like you're almost treating them like children, like they couldn't address their behaviour. Like they couldn't learn how to have good bedside manner. Mm-hmm. Really? Yeah. They couldn't handle that. But yeah, in this climate of fear around diversity, equity and inclusion, everyone you talk to, it seems that there's what you can say when there's other people around, and then there's what you can say when the HR person isn't listening, which is what you actually think. That's I mean, that's why I'm doing this podcast, people, because I think at this point, again, we're not in the 90s anymore, and we can't just close our eyes and pretend this isn't happening. It's getting to the point where the whole system is clunkingly, chuggingly just kind of seizing up and coming to a halt under the weight of all of these problems that we're unable to address, we're unable to solve because people are afraid to even talk about it.
Yeah, definitely. And we've seen in the NHS's history, whistleblowing is very difficult for people. And the most extreme case we saw of that was Lucy Letby, who was the NICU nurse. And that went on for so long because people were too afraid to whistleblow and too afraid to say, this person's behaviour is weird, this keeps happening on her shift. That's classic NHS. You just wouldn't, the culture isn't there to be able to whistleblow freely.
And that's an interesting example as well, because of course Lucy Letby was a white English woman. So again, this isn't just a kind of it's the people from other countries. It's the culture itself. I mean, what do you think that comes down to? Where do you think the problem with that culture lies? And do you have any ideas on what could work to address it?
I really don't know. I don't know where it comes from. Maybe it's kind of like this lack of personal responsibility that people have in the NHS where, you can just kind of come in and do your job and you're not, because you can't get fired, you just oh, well, it's not my job to whistleblow that, or it's not, that's above my pay grade, or maybe it kind of comes from this lack of personal responsibility. But yeah, I really don't know. It must be multifactorial. There obviously isn't just one thing, but it is a deep-rooted problem in the NHS. We saw it with Lucy Letby, we saw it with the mid-staff trusts. There was this whole massive inquiry because there was excess deaths in Mid-Staffordshire Trust. This was years ago. And then they had this massive public inquiry and all these new things came out for NHS people to follow. So we know that it happens, and we know the problems of people not being able to whistleblow. And that, what we were just saying, that can stem from not being able to say to someone, your behaviour is not acceptable in our culture. Could you try and change some of your practices, to the most extreme case of Lucy Letby? And I'm not saying that people from West Africa are going to be like Lucy Letby at all, but you can see where the problem starts and how bad it can get when people can't speak up and they can't say the truth.
Well said.
Yeah, thanks. With most of the dead wood is in middle management and management, which we can see evidently in the financial deficits of the trusts, can't we? So you can kind of see where things start to go wrong.
That's a really good way of kind of closing the circle there. All that deficit, all the money we're throwing at the NHS, and where is it going? Well, it looks like a lot of it is going on incompetent and, I don't want to say completely useless, but certainly low priority middle management roles, such as carbon neutral and the diversity people, who again, how you can think that a trip to Devon is worth saving, or that you need to, give everyone an interview, again, when people's relatives are dying in the hallways. This is mad. This has to change.
Definitely. And you can say, £80,000 to 33 million deficit. Oh, it's a drop in the ocean. It's not that much, but it's a symptom, isn't it? It's a symptom of the wider problem of wasting money and not using the money effectively for change, proper change. So yeah, it's a drop in the ocean, but if you scale it up, that's where you see £33 million of a deficit.
And I'm just thinking, you look at the salary of the carbon neutral guy or the diversity person, and you think, how many nurses could I get for that? how many people could be spared that indignant death if we spent that money more responsibly and we got our priorities straight. Now, there's one more thing I wanted to ask you about, Becky, in terms of bizarre things going on at the NHS. I saw this recently. I don't know what you think about this. I have to be honest, this just blows my mind. Okay, so this is an article. So this was been talked about on LBC. It says, trans women's milk just as good as women's for feeding babies, NHS Trust insists. And that's dated the 19th of February 2024. And I'll just read a bit of this and then I'll get your thoughts. So it says, a letter from the medical director at University Hospitals Sussex NHS Foundation Trust made the claim as part of a response against campaign groups. It defended the use of drugs to induce lactation to help trans women feed babies. Dr. Rachel James's message said, quote, medications are sometimes used to induce lactation similar to the natural hormones which encourage lactation to develop when the baby is newly born, although occasionally some people are able to induce lactation without hormonal treatment. The evidence which is available demonstrates that the milk is comparable to that produced following the birth of a baby. Now, I try to be a fairly unbiased interviewer on this show, but you can probably hear I'm struggling to conceal the visceral disgust that I have at the thought of this. This is just beyond comprehension. So this is an NHS trust. I mean, I don't even know what to say to this. Apparently this is real in 2024. Becky, you work in the NHS. What do you make of this?
Yeah, I find it weird as well. Really, really quite strange. So kind of looking at it at two angles. So I can look at it me working in the NHS, and we can talk about the drugs that they use and the process, kind of like what I've read into it. They have to be on these drugs for a long time. So it's not just the baby's born, they start taking the drugs and they produce milk. Like, they have to be planning this for about 9 months. They have to be taking increased levels of progesterone, and they'll be taking a drug called domperidone, which will induce the lactation. And they also have to pump, because breast milk is kind of done on supply and demand, right? So you have to pump in order to produce milk, to produce more milk. So it's a process of about 9 months that they have to do this for. And the drug domperidone that they use, we don't use it as often now. It's actually an anti-sickness drug. Mm-hmm. But it has this off-license indication. It's used for women as well who don't produce enough breast milk, but it has some pretty nasty cardiac side effects. So we don't really use it that much. We'll only use it in people undergoing cancer treatment for severe sickness. Mm-hmm. They say it doesn't leak through to the breast milk, but I don't know. Like, you're putting this trans woman through this process and you're giving her this drug that could cause her irreversible cardiac problems. For what? For what? Just so that they can have this thing where they can feed a baby? Like, if they already have a mother who's producing breast milk, why do they need to do this? It's so weird.
Yeah, it's again, I want to try to be objective about this, but I really struggle to remain in the objective role when talking about this, because it just feels like something where, just on a sort of gut instinctual level, I want to pay everyone the compliment of assuming everyone knows this is wrong. This is just like deep, primally wrong. That people, I mean, there's like, where's the consideration for the risk to the baby?
Yeah.
You know, they're just like, oh, this will be fine. You're taking that assumption on behalf of a completely defenseless newborn baby, I mean, nutrition for infants is going to affect their development. If they have something that is toxic, that could give them lasting damage, developmental issues. Same with just simple malnutrition. And I cannot understand how anyone could even entertain the idea of this without just dismissing it out of hand. I mean, do you happen to know if the NHS is funding any of this treatment, or if this is just their recommendation based on what people might themselves fund privately?
I would imagine it would be done through the NHS. Yeah, I would imagine that this trans person would have gone to their GP, or it would have been done if they were in a relationship with the birth mother. It might have been done at a midwife appointment or something, and gone to consultant level. But yeah, I would imagine that NHS would give the treatment. Yeah.
Do you have any idea of how much money they would be allocating to this treatment?
The drugs are pretty cheap that they use. They're not expensive, but it's off license and it's very specialist. So the doctors prescribing these treatments are probably going to charge a lot of money for their time. So they're probably consultants. I can't imagine a GP actually prescribing it because it's off license. So they probably wouldn't be comfortable. But it's not the money. It's just the whole thing is just not right either. Yeah. And I have a big issue with like people who defend this, like saying it's okay, when we like the breastfeeding rates in this country are appalling for actual women, and there isn't enough support for actual women breastfeeding because it is very difficult mentally and physically, and there's no support out there from the NHS for breastfeeding, and yet they'll support this trans person who wants to do it. Like, it's not right, I don't think.
Can you tell me a bit more about that in terms of the, so there's an issue with not enough women breastfeeding, and why do you think that is, and what sort of support do you think they need?
So I think it's after 6 months, only 1% of women are breastfeeding their babies, which is tiny. It's kind of a mix of things. So culturally, people find it easier to bottle feed sometimes. Some women don't like the thought of breastfeeding. Some people just can't breastfeed. They have medical issues that they can't. And a lot of it is women will start breastfeeding and they love it and they can see the benefits, but it's really hard. It's a difficult thing to do physically. It hurts your body and mentally as well. And the baby, it's not just a simple they'll latch on and drink the milk. There's a lot of issues that can happen, and there is no support for women. Like, there are little hubs and stuff set up, but quite often you need one-to-one advice for breastfeeding, and that's not a service that's offered by the NHS. So I have friends, and myself included, I've paid private midwives to come to my house to help me breastfeed because there was no support from the NHS for this. And the solution from the NHS is, we'll just top up with formula. And it's like, I don't want to do that. I want to breastfeed my baby. I want to give them my milk. And there was no support, and yet they will find support for a trans woman.
Yeah. So it seems that it's not that we're not spending enough money on the NHS. It's what NHS management are choosing to spend that money on. And to sort of paraphrase a famous line from Saving Private Ryan, I think you could say that constitutes a serious misallocation of valuable resources.
Yeah, for sure.
So another thing I wanted to touch on was kind of going back to something we talked about last time, which was things around COVID, which we are now able to talk about on podcasts, whilst a few years ago even saying COVID on online meant that you could get your channel suspended, you could get censored, even if you were one of the most widely published and cited medical experts on on related issues in the world, so we can actually talk about it, which is nice. And just kind of three things. I think we touched on this last time. It's the medicines that were demonized and were not utilized during COVID that is something it's kind of really bugged me since then, because it seemed like the response to COVID was all based around prevention and wasn't focused on treatment. And so there was a huge emphasis on social distancing, on wearing these masks, and on being locked down and kept in your home. There wasn't much emphasis on the risk factors such as exercise and obesity and diet. But also there was practically nothing said around treatments that were reported to be effective in treating patients who had COVID-19. So I'd be interested to kind of hear your thoughts on that. I know we touched on it last time, but there were three medications in particular that I heard were effective for this, though people tried to kind of dismiss them as, it's a conspiracy theory, it's Alex Jones must be talking about this, and yet there were medical experts saying no, this stuff actually works. But so particularly as you work in pharmacy, so the medications I heard of that were effective were hydroxychloroquine, ivermectin, and monoclonal antibodies. I know that's maybe a bit different, but what can you tell us about those?
Yeah, so hydroxychloroquine is used for arthritis predominantly. Ivermectin is for like parasitic diseases. I think the famous quote in the media was horse dewormer, which yes, it's used in horses, but a lot of human medicines cross over to veterinary medicines and nobody cares about that in real life. So that was kind of blown out of proportion. I did a bit of reading about this actually after our last podcast because I admittedly didn't know anything about this because it's just not like discussed at work and it was never an option at work. And yeah, there seems to be quite a lot of evidence behind ivermectin particularly. I think there's definitely less evidence for hydroxychloroquine. But yeah, ivermectin, there does seem to be some good evidence behind it for treatment of COVID, mild COVID this is, and from what I read, there was some good evidence about taking it prophylactically for healthcare workers. For example, when I say prophylactically, I mean like for prevention. There was some evidence that, if healthcare workers were taking it, they were less likely to catch COVID. So actually there was a bit of evidence behind it being more effective than a vaccine, or like something that we could have used before a vaccine was developed.
So that could have made a huge difference for frontline NHS staff, to say nothing of, the patients and the people at large.
Yeah.
And that just seems so strange that you didn't hear anything about that, in the NHS. I mean, were people talking about, back in, I guess, 2020 when this really kicked off, were people talking about treatments and options for that?
Yeah, people were always talking about different treatments, and there were different treatments coming in all the time. So like from what I remember, there was this high dose vitamin D thing that came in. There was dexamethasone, which is a steroid, which is still used for COVID, because COVID is quite an inflammatory disease, so using steroids kind of makes sense. There was like a couple of clinical trials going on. One was the recovery trial, which is for monoclonal antibodies called tocilizumab, which is now licensed for COVID, severe COVID. So there were clinical trials going on, but like now I'm reading about this ivermectin stuff, I'm like, okay, so there was some evidence for it, so why couldn't we have done a clinical trial for it? Because we were running clinical trials during COVID for COVID treatment, so why couldn't we have done that for ivermectin, like, or anything else? It just seems to be like it was quite limited on what they were doing. So that was quite strange to me. And I read there's a doctor from the evidence-based medicine committee or something. She wrote a letter to the Prime Minister, Matt Hancock, and a couple of other MPs. She actually did some meta-analysis on data from ivermectin studies in COVID herself, and found some strong evidence, and her letter was ignored by the government. She submitted some evidence actually in the COVID inquiry, which was quite interesting to read.
Wow. So they had this option which could have helped to prevent NHS staff and the general public from contracting COVID-19. There was evidence that this was effective at the time, and yet even though medical experts were saying, look, we've got something we should explore here, the government was completely ignoring it.
Yeah, I don't know why. Because like I say, there were trials going on at the time, so there wasn't any ethical problems with doing that. So why couldn't they have done that?
Now, I've got a question that actually I should have asked you a while back in the conversation. So whether I splice this in later or and edit it in, or we just keep it here. Going back to hiring staff, one thing I didn't ask is that given the difficulty with recruitment, have entry requirements and standards been lowered?
I don't think so for professions such as doctors and nurses and like qualified registered healthcare professionals. That being said, again, the way the interview process works, if you score the highest, you have to be offered the job. And if they're using questions that aren't relating to how you do your job, then you can see where problems might start to arise. There certainly hasn't been any like lower of requirements for grades and stuff to get into medical school and nursing school and stuff like that. Maybe there's less people applying, so the pool of people, are not as good as maybe before.
Do you think that? Sorry, I was going to ask. Do you think that impacts the extent to which people are able to progress as a career? You know, if you're having people come in who are perhaps less able to begin with, does that mean that whilst you would normally invest in someone and hope that they would progress and have a career, that a lot of the people coming in, there's only going to be so far that they can ever go, and that's going to be less, as in we'll have a problem, there's talk of the skills crisis or the competency crisis. Are we going to be in a situation where we just don't have people that can be promoted beyond a certain point in sufficient numbers because the people who were recruited in the first place just had limitations that they won't be able to overcome?
That could be a problem in like administrative roles, and maybe unregistered healthcare professionals like healthcare assistants and carers. But I don't. The issue that I see with registered healthcare professionals is the fact that now that they're not funding training courses, you might see maybe a different demographic who might have the excess money to be able to afford that, and it kind of limits the pool of people. I think unregistered staff, it's difficult for them to progress anyway because of this whole banding thing in the NHS. And so again, like, you could be an amazing healthcare assistant and you could be fantastic at your job, but after say 10 years, you will never earn more money. You will be stuck at that money for the rest of your career, which could be 40 years.
Wow.
Yeah. And there's no way they can progress because unless they become a nurse, there's nothing else they can do.
Another question I wanted to ask, and this was actually, I asked around if people had any questions for you, Becky, and my mum said, can you ask her, why can you only book a GP appointment 2 weeks in advance?
Yeah, there's a couple of issues in primary care. So you have the GP practice. The proportion of GPs to patients is unmanageable in certain cases. So, for example, the town we live in, it's quite a large town. So our GP practice probably has about 15,000 patients, maybe. So it's quite a lot of patients. And I think on the list there might be 10 GPs, and most of them are part-time. So to get an appointment, because they only work Monday to Friday, 8 till 5 or whatever, you can kind of see where it becomes a problem to be able to book an appointment. There's a lot of wasted appointments. A lot of people don't turn up to appointments, so they'll waste that. There's a lot of talk about actually fining people for not turning up to appointments, because it is a big problem in primary and secondary care. Waste a lot of time. You'll have people coming to the GP for reasons that they don't really need to come to the GP for. They could have just gone to the pharmacy, or if they were just educated about their health, they probably could have just bought something over the counter to help them, or come in wait a little bit. So there's lots of different reasons why the GPs are under a lot of pressure. I know people like to hate on GPs. I'm the same. I often moan about my GP a lot, but I've worked in a GP practice, and there are pressures there, definitely. It's hard for them to fit in. And when you get a good GP, they really feel this. They feel a lot of stress about not being able to see their patients and not being able to have a good relationship with their patients like a GP 50 years ago would have. So it used to be you'd have a family doctor, isn't it? And you'd just call up, you'd be able to just go and see the family doctor. They'd often come to your house. You'd have a much more personal relationship with them, but it has changed so much because of the increase in the population and the amount of time it takes to train a GP. You can't just recruit GPs into these roles. You have to invest in the staff from graduate level to get them to a GP. It will take about 7 or 8 years for them to get to GP level. So we should be starting now with investing in these young doctors and getting them to be GPs, so there's more of them, but that's not really happening either.
No, it seems like they're doing the opposite. They're withdrawing funding for people going into the health professions at the same time as, I think immigration, I don't know if it was last year, but it's been over 1 million people coming into the country. And it just blows my mind, because number one, I don't understand who's driving this. Everyone knows that mass immigration is overwhelmingly unpopular, even amongst immigrants, even among people who've already come here. If you survey them, they will want to, pull up the drawbridge behind them, because they can see that the more people who come, if they come in such large numbers, then that's going to mean that there is more competition for scarce resources. And I believe the population has increased by at least 20 million in the last few decades. And house prices, as they are, reflect the huge increase in demand for housing relative to supply. We've not been building houses. Whether it would have been possible to build on that scale is a question you kind of wish they would have asked themselves 20 or 30 years ago before they did this. But then this is another consideration that they clearly haven't made, is that, well, there are other resources that are being drawn down on, and if you import millions and millions of people into the country and expect the National Health Service to be able to cater to this huge increase in demand without increasing their funding, but and again, it's difficult because NHS funding does seem to have been going up, and yet it doesn't seem to be being spent on the right things, and it certainly isn't delivering the results. But even if it is going up, I'm not sure if they're allocating resources at a scale that would be necessary to cater to such an absolutely unprecedented increase in people who are here and are going to get sick and are going to need help.
Yeah, I think you're right. That's definitely another factor, is that, yes, the money is misspent, but also maybe not enough money is being put in to, what am I trying to say? To make up for the amount of people that are requiring the funding. That's definitely an issue. I mean, you only have to open your eyes and you can see the amount of extra people now that are living in the country. I mean, you don't only have to commute to work, and it is impossible to drive around the towns. You can't get a GP appointment. You can't send your child to the school that you want to send them to because it's so oversubscribed. Like, we see it in all of these public services, and yet the root issue is still not being addressed.
Yes, and I don't know why. Because, I mean, I keep looking at the situation and thinking, who is benefiting from this? I mean, there was that Tory MP who was stabbed to death in the street, I think a year or two ago, and he was stabbed by an immigrant who had been imported from some country, and even that doesn't seem to have been enough to make them U-turn on mass immigration. I mean, to my knowledge, every single survey that has ever been taken of British public opinion on do we want immigration, do we want mass immigration, the overwhelming answer has always been no, we don't. And I don't know why that isn't taken into account, whether it's dismissed as, mere bigotry, as though the consideration for resources for housing, for healthcare, and all the other resources that are now much more in demand, and there's much, much less to go around. And of course, these are people who are coming in not having been paying into that limited pool of resources through taxation over any of their life before then. And suddenly they just get to draw down on it, and they can use it just as much as you or I, who have to pay a huge chunk of our income in taxes to fund these government programs. I mean, I just don't understand why they're doing it and what they're hoping to achieve. But anyway, that's kind of speculating beyond what we were kind of here to talk about today.
I agree, though. I think it's illogical. Yeah.
There was one more thing I was going to ask you about, which I think is again very interesting, because I think real people's experiences are what people want to hear about. We've talked a lot about COVID and about how things happened and what that was like for NHS staff. But you mentioned to me before that your husband was also a frontline NHS worker during that time, and that he had some, pretty difficult experiences, as I'm sure many, many, many people did. So would you like to share a bit about his experiences?
Yeah, I think my husband, he's more frontline than I am for the COVID stuff, because I was on maternity leave for the first wave. So he definitely had a more first-hand experience than I did for that first wave, which was like the most scary time, I think, for NHS workers, because it was just so unknown. And it was literally overnight. So when lockdown was implemented, he went straight onto 12-hour shifts. And his workforce, he's a physio, so his workforce was kind of split up. Because he works in orthopedics, there was only like emergency cases coming in. There was no planned surgery anymore. So a lot of his colleagues were moved over to ICU. His physios are trained in ICU. It's part of their core competencies. They have to do respiratory physio to help people breathe when they're coming off ventilators and to suck up secretions that are caused by the ventilators. And that was a really hard time for us personally, because I was on maternity leave and I had a 6-month-old baby at home, and then suddenly my husband's working 12-hour shifts and we're in lockdown and I'm socially isolated. I didn't see a human being for 14 hours of a day apart from my baby. So for our little family, it was a really, really difficult time. And then my husband caught COVID from a patient that he was treating without a mask, because the mask thing just kept changing when you needed to use one and when you were allowed to use one, when you weren't allowed to use one.
Is that because they were in limited supply at that time?
Yes, yeah. They had no PPE at that time. It was right at the beginning of the first wave. They didn't have enough. When I say masks, I mean like the proper FFP3 masks, the respirator masks. They didn't have enough supply of the masks, and they had to train everybody to fit the masks. It's quite difficult to get a good suction of the mask on your face. So men had to be completely clean shaven, for example, so you had to be tested to make sure you're using it properly. So all people had for protection really at that time were just like plastic pinafores and surgical masks. But when you're treating a patient who is like coughing in your face, and physios have to get really close to people, you're obviously going to catch something if you're just wearing a surgical mask or no mask at all. And he got really sick with COVID. He has a bit of an underlying lung condition. He has something called sarcoidosis, which is like an inflammatory lung thing with lymph nodes in his lungs. So I think that's why he got it so badly, because otherwise he's a really fit and healthy young person. We had to call an ambulance for him. It was pretty bad. But he did recover. And after 2 weeks, he was able to go back to work. And he remained on 12-hour shifts for quite a long time, which put a really large strain on the family. And then I have friends who are nurses. One of my really close friends is a nurse. She was a trained recovery nurse, so she was used to working with ventilators. So the trust decided to move all of those nurses into ICU, which is fine, but she was also on maternity leave. So the day she returned from maternity leave, she was just thrown into ICU, into this pandemic ICU, and she was so overwhelmed. She wasn't trained properly. And she actually developed some pretty severe mental health problems and had to be signed off sick for a good year after that, which is really sad because she was a great nurse. She's back to nursing now and she's fine. There's just these like little first-hand experiences of like actual people's lives when you start to realise the impact of everything that happened, and the supply of PPE, people getting sick, lockdowns. When you start to hear actual human stories about it, it hits home a bit more.
Becky, thank you very much for coming on the John Doe podcast.
Thank you. Again, I hope I wasn't droning on too much and being negative. I hope everyone enjoyed what we had to say, and I'd be happy to come back again because there are still lots more things that we can talk about.
Brilliant. I look forward to it, although I know that some of those are probably going to be gloomy and concerning topics. I think it's things that it's important that we can talk about and speak freely and openly and honestly about. And I think we're not going to solve any of these problems whilst we live in this culture of fear. And I think talking about it is the first step. Of course, I'm doing this anonymously because right now there still is the tyranny of the HR department, and those conversations that you might have, you can't always say what you really think. So again, at one point in time, I would like to be able to do this where we can just come out and say like, this is who we are. But right now, I think we've got to start from where we are, which is having the conversations and making the information available to people. So I hope this has been interesting. I hope you've enjoyed this. Thanks very much for those who've stuck it out for the full time that we've been going. If you have enjoyed this content, then please do like the video and subscribe. This obviously helps to get the video shared more widely. Please recommend it to any friends or anyone you think would find this content interesting, and any feedback in the comments will be read and appreciated. So thank you very much, everyone. Becky, thanks again for joining.
Thank you very much.
And we'll see you all next time. Bye for now.